Welcome to the deep dive. Ever had that annoying pain right on the front of your knee? Maybe with a bit of puffiness? Today we're diving straight into prepatellar bursitis. You might know it as Housemaid's knee, maybe carpet layer's knee.
Exactly. And think of this as your focused revision session on this condition.
Right.
We're aiming to pull out the absolute key info, what it is, what causes it, how we manage it, get straight to the point.
Okay, so prepatellar bursitis. Sounds a bit formal. Let's unpack that. What's actually happening there?
Okay, so the clue's in the name, really. Bursitis just means inflammation of a bursa.
And a bursa is?
Yeah, good point. A bursa is like a tiny little fluid-filled cushion. We have them around joints, basically to stop things rubbing together, reduce friction between bones, tendons, scales.
Shock absorbers.
Sort of, yeah, more like friction reducers. So prepatellar bursitis is specifically when the bursa that sits right over the front of your kneecap, the patella, gets inflamed, swollen.
And prepatellar just means in front of the patella.
Spot on. Location, location, location. It's very superficial, just between the skin and the kneecap bone.
Okay.
And this is important. It doesn't actually connect into the main knee joint itself. That joint space is usually fine.
So the problem is outside the actual joint cavity.
Precisely. There are other bursas around the knee, sure, but today it's all about this prepatellar one.
Got it. So what tends to set this inflammation off? What are the common culprits for this specific bursa?
Well, the big ones are repetitive, sort of, minor impacts, constant kneeling, crawling, hence the nicknames, right?
Housemaid's knee, carpet layer's knee. Makes perfect sense.
Yeah. Also, a single direct blow, like falling hard onto your kneecap, can do it, and prolonged pressure, just resting on your knees for ages.
And infection, you mentioned that.
Yes, infection is another key cause. Bacteria can get in, often through a small cut or scrape, and set up shop in the bursa.
Okay, so if we were to group those causes, how would we think about them?
Good way to approach it. You've got acute trauma, that direct hit, then recurrent minor injury, the kneeling stuff, then infection. Remember, Staphylococcus aureus is a common bug here, especially in kids.
Staph aureus, right.
And then sometimes it's linked to other underlying problems, things like inflammatory diseases, say rheumatoid arthritis, or crystal conditions like gout or pseudogout.
So underlying health issues can predispose you.
Exactly. They can make the bursa more likely to get inflamed.
Okay, which leads nicely into risk factors. Who's more likely to get this beyond the obvious job titles?
Well, the occupations are a big one. Carpet layers, gardeners, cleaners, plumbers, anyone spending a lot of time on their knees.
Makes sense.
Then you've got people involved in contact sports, maybe direct impacts or falls. Also, a history of previous knee injuries can increase the risk.
And the infection risk.
Yeah, so anyone who is immunocompromised, their immune system isn't working at full strength. They're definitely more vulnerable to the septic type of bursitis. So occupation, sports, previous injury, immune status, those are the key areas.
Okay, we know the triggers, who's at risk. Let's talk pathophysiology. What's happening at a biological level?
So with the trauma or repetitive pressure, you get irritation of that bursa lining. This triggers an inflammatory response.
The body's reaction.
Exactly. The body sends inflammatory cells, releases chemicals, and crucially, the bursa starts producing extra fluid. That's what causes the swelling, the effusion.
And if it's infection?
If bacteria get in, say through a little break in the skin nearby, they multiply inside the bursa. This triggers a much stronger inflammatory response. Think pus formation, more pain, more redness. It becomes an infected space.
Right, much nastier. Okay, so someone comes in, brought a knee pain, swelling. It sounds like prepatellar bursitis, but what else could it be? What are the main differential diagnoses we need to consider?
Oh, absolutely crucial. You can't just assume. You need to think broader. Could it be inflammation inside the knee joint itself, like arthritis?
How would that differ?
Usually, arthritis involves the whole joint, maybe more diffuse swelling, not just that pocket right on top of the kneecap. Pain might be deeper in the joint.
Okay, what else?
Patellar tendonitis, that's pain usually below the kneecap in the tendon, often related to jumping activities. Think jumper's knee.
Right.
Meniscal tears, they typically cause pain with twisting, maybe locking or clicking inside the joint. Patellofemoral pain syndrome is more of a general ache around or behind the kneecap, often worse going up or down stairs.
Okay.
And the big one you really don't want to miss is septic arthritis of the knee joint itself.
Infection inside the joint.
Yes. That's a surgical emergency. Usually much more systemically unwell, more pain with any movement, not just localized swelling over the patella. Also consider cellulitis a skin infection, which can look red and swollen too. and maybe infrapatellar bursitis, inflammation of the bursa just below the kneecap, though management can be similar.
So careful examination and history are key to pinpointing it.
Definitely. The superficial swelling right over the patella is the classic sign for prepatellar.
Let's talk numbers then. How common is this? Any UK data?
Yeah, the estimate in the UK is around 1 case per 10,000 people per year. So not super rare, but not incredibly common either.
And demographics?
Tends to be more common in men, often in that 40 to 60 age bracket. And again, linked to those occupations, cleaners, gardeners, roofers, also seen in sports with knee stress, like basketball or wrestling.
And the septic versus non-septic split?
That's quite significant. About 30%, roughly a third, of cases are thought to be septic.
Wow, nearly 1 in 3.
Yep. And those septic cases are seen more often in children and, as we mentioned, immunocompromised people. So that 30% figure is worth remembering. Always consider infection.
Definitely. So clinical features. What does prepatellar bursitis actually look and feel like to the patient and the examiner?
Okay, so the patient typically complains of pain right at the front of the knee, over the kneecap. There's usually visible swelling, like a small cushion or water balloon there. It might look red. Kneeling is often very difficult or impossible due to pain. Walking might be uncomfortable too. And crucially, if it's septic, they might feel generally unwell, maybe have a fever.
And what would a clinician find on examination?
You'd see that swelling, typically well-defined and superficial to the patella. Pressing on it would cause tenderness. The area might feel warm to the touch and look red erythema.
Okay.
Knee movement might be a bit restricted, mainly due to the pain and swelling at the front, but the actual joint range might be okay if you're gentle. And in septic cases, you're looking for those systemic signs, fever, maybe a fast heart rate, looking generally unwell.
So when taking the history, what specific things are you asking about?
You definitely want to nail down the occupation. Do you kneel a lot for work or hobbies? Ask about any recent falls or direct hits to the knee.
Trauma.
Yep, any repetitive knee motions, recent steroid treatments for anything. Are they immunocompromised, diabetes, on certain medications? And importantly, any history of gout, pseudo-gout, or other inflammatory joint problems.
Right, covering all those potential causes and risk factors.
Exactly, you're building the picture.
Okay, picture built. How do we confirm the diagnosis and, most importantly, figure out if it's infected? What tests are key?
The single most important investigation is aspiration of the bursa.
Sticking a needle in.
Basically, yes,
No.
under sterile conditions, obviously. You insert a needle into that swollen sac and draw off some of the fluid. This is primarily to distinguish septic from non-septic bursitis. It's crucial.
And what happens to that fluid? What are you looking for?
It gets sent to the lab for analysis. They'll look at several things. White cell count, a high count, say over 5,000, suggests infection, though inflammation alone can raise it too.
Okay.
Protein and lactate levels might be up. Glucose might be low if bacteria are eating it. But the absolute key tests are gram stain and culture.
To find the bugs.
Precisely. See if any bacteria grow. Usually Staph aureus if it's septic, but could be others. They'll also look under a microscope for crystals.
For gout or pseudo-gout.
Exactly. Needle-shaped monosodium urate crystals mean gout. Rhomboid-shaped calcium pyrophosphate crystals mean pseudo-gout. Sometimes you might even see cholesterol crystals, maybe linked to rheumatoid arthritis.
So that fluid tells you a lot: infection, crystals, inflammation level.
It's the diagnostic cornerstone, really.
What about imaging? Do x-rays or scans play a role?
Usually not needed for the initial diagnosis if the picture is clear,
Yeah.
but you might get an x-ray if you suspect a fracture from a fall or maybe a dislocation.
Makes sense.
If you're treating for septic bursitis and it's just not getting better, then an MRI or maybe a CT scan could be useful to look for complications, like an abscess or deeper infection spread. Ultrasound can sometimes be helpful too, just to confirm the fluid collection or maybe guide the needle for aspiration.
So imaging is more for specific questions or complications, not routine.
Generally, yes. Aspiration is the main event for diagnosis.
Right. Diagnosis made. Let's talk treatment. How does management differ for non-septic versus septic prepatellar bursitis?
It's quite different, as you'd expect. 2 main pathways.
Let's start with a more common one, non-septic. What's the approach?
For non-septic, we usually start conservatively. Think price protection, rest, ice, compression, elevation. So stop doing the activity that's aggravating it.
Avoid kneeling.
Absolutely. Use ice packs to reduce swelling and pain. Simple painkillers or anti-inflammatories like ibuprofen, NSAIDs can help. Protective knee pads are really important if kneeling is unavoidable for work.
Practical stuff.
Yeah, patient education is key. Maybe a foam cushion? Sometimes physiotherapy to maintain knee movement can be beneficial.
And if that's not enough?
Then we might step up. Aspiration can relieve the pressure from the fluid buildup, and sometimes, if you're sure there's no infection, a corticosteroid injection into the bursa can really calm the inflammation down.
Steroid shot. Okay.
Yeah.
But only if infection is ruled out.
Cannot stress that enough. Injecting steroid into an infected bursa would be disastrous. Oral NSAIDs might also be prescribed if over-the-counter ones aren't sufficient.
And surgery. When did that come into play?
Surgery, usually a bursectomy removing the bursa, is generally reserved for chronic, recurrent cases that just aren't responding to anything else. It can be done arthroscopically, keyhole surgery, which often gives better cosmetic results, or via a traditional open approach.
Okay, that seems logical for the non-infected type. Now, what about septic bursitis? That sounds more urgent.
It is. Septic bursitis needs antibiotics promptly. You'd usually start with empirical antibiotics, ones that cover the likely bacteria like Staph aureus.
Before you know the exact bug.
Yes, while waiting for the culture results from the aspiration fluid. Once you have those results, you can switch to a more targeted antibiotic if needed.
Makes sense. And what else? Just antibiotics?
Often not. Repeated aspiration might be needed to drain the pus. Sometimes irrigation, washing out the bursa, is done too. If it's severe or not responding, surgical drainage, which might involve opening up the bursa or even removing it, bursectomy, might be necessary to clear the infection fully.
So, much more active intervention needed for infection.
Definitely. Antibiotics and usually some form of drainage.
Okay. Looking ahead, what's the usual outcome? What's the prognosis like, and are there any nasty complications to worry about?
Generally, the prognosis is pretty good, especially for non-septic cases treated appropriately. Most people find symptoms improve over weeks to months with conservative steps.
That's encouraging.
However, it can recur, especially if the underlying cause, like frequent kneeling, isn't addressed. Some people might develop chronic nagging bursitis.
And complications.
They're relatively rare, thankfully. The main ones are persistent infection if septic bursitis isn't treated effectively, potentially leading to an abscess. And as mentioned, chronic inflammation and pain.
So prevention is important too.
Absolutely. Educating people in those at-risk jobs or activities about avoiding prolonged kneeling where possible and consistently using good knee pads or cushioning can make a real difference.
All right, so to quickly recap, prepatellar bursitis inflammation, front of the kneecap bursa, caused by kneeling, trauma, sometimes infection. Aspiration is key to check for infection. Non-septic, rest, ice, NSAIDs, maybe aspiration steroid. Septic needs antibiotics, often drainage.
You've got it. Understanding those causes, knowing when to suspect infection, and choosing the right management path, that's the core of handling it effectively.
It really makes you think, doesn't it? Considering how common things like gardening or cleaning are, what other sort of seemingly minor repetitive stresses might be causing similar bursitis issues elsewhere in the body? Something to ponder.
That's a great point. It really underscores how these cumulative low-level stresses can build up and cause problems in various joints over time. It's not always about the big, dramatic injuries.
Definitely food for thought. Well, for everyone listening, if you want to solidify your knowledge on this and other key conditions, do check out PassTheMSRA.com and also FreeMSRA.com for more excellent resources. Thanks for joining us for this deep dive.